Rivas. I am from Horizon Therapeutics. I'm a senior communications manager there, and I have a decade of health equity experience doing this work, and this conversation is so important to my heart, the conversation of intersectionality when it comes to all of us as multifaceted human beings, whether you're living with a rare disease, you come from a different ethnic or racial background, the way you show up in the world is unique to you. And I'm so excited to share this conversation with everybody because I think there's going to be some really meaningful takeaways and, as discussed earlier, some very tactical things that you can do and ways that you can shift the work that you're doing. It's an honor to be here with everybody who is already doing so much of this work. So very excited to share in conversation with our folks here. So Daniel, would you like to introduce yourself?
Hi, my name's Daniel. I am a Chinese adoptee. I have one other sibling from China and two from South Korea. I live with a rare disease called tuberous sclerosis complex, also known as TSC. Have vital organs complications with, as well as skin manifestations, benign tumors, and other learning challenges. I've been advocating within the rare disease or TSC community for since 2017, mainly just looking for answers. And it's just stumbled across and really found an area that needs to be addressed, not only for the rare disease, but in the adopted community as well.
Thanks, Daniel. Dr. Hiratsuka?
Hello, everybody. I first would like to just acknowledge where we're at, and that is on the Kumeyaay lands. I myself, I am Diné, and I'm Winnemem Wintu from Northern California, so it's really a blessing to be back here in my home state, although much, much further south. So again, I just am very grateful to be a guest here on Kumeyaay lands, as all of us are. I am an assistant professor. I'm a public health researcher, a mom of two, a wife, somebody who is so nervous to be up here on this panel because I'm usually the guy behind the guy. So in my work, I tend to be somebody who is behind the scenes more so than in front, although all of us are leaders, and I'm hoping that's one of the things that I can talk a little bit about as I'm on a panel here. I'm one of the multiple principal investigators on a couple different studies, so I'm a bioethicist. I am an MPI of the Center for the Ethics of Indigenous Genomics Research. I always forget how that acronym goes. And I also work at a University Center of Excellence on Developmental Disabilities. It's really a pleasure to be here with you all.
Hi, I'm Dr. Neena Nizar, and I'm happy to be here today. So I have a ultra rare skeletal dysplasia, affects less than 30 people worldwide, Jansen's metaphyseal chondrodysplasia. And I was diagnosed when I had my second son. So I've lived with the identity of a disability long before I actually had the identity of a rare disease patient, and then caregiver, and then foundation leader. And so I've worn several hats, and then in the middle of all that, a researcher to find a treatment for my sons. So talk about intersectionality. Yeah. So I'm here and happy to be on this panel. I also recently joined the patient advocacy strategy team at ICON PLC, where we do a lot of DEI work in the space and help communities achieve some of their DEI goals. So I'm happy to be here.
Thank you so much, everybody, for that introduction. So before we get started, I want to bring up the conversation of health disparities and health equity in general. You know, we've had kind of a brief overview, but defining health equity really needs us to have this discussion. So health disparities are differences that exist among specific population groups in the US in the attainment of full health potential that can be measured by differences in incidence, prevalence, mortality, burden of disease, and other adverse health conditions. But the term disparities is also often used to reflect differences between racial or ethnic groups, including gender, sexual orientation, age, disability status, socioeconomic status, and geographic location. So to start off this conversation, I wanted to make sure we were level setting and really what we're planning to discuss. As many in this room know, 1 in 10 people here in the US lives with a rare disease. And another thing we wanted to bring to the forefront is about 19% of the population also lives with a disability. So when we talk about the rareness of this conversation, it is actually very prevalent. So very excited to be able to bring that up. So one of the things I wanted to start with is why intersectionality is really critical to this conversation. We're not talking about just cultural values or racial or ethnic categories, but the ways in which we define some of these terms. So I wanted to ensure the experts had an opportunity to bring their own definitions to the forefront. So Daniel, is there anything you'd like to add in terms of how we discuss adoptee?
It's really adoptees, from my perspective. Well, when I was in a call from another adoptee event, someone told me that, which I never thought of, adoption is a transaction. People don't realize that. I mean, just like if people go to adopt a cat or dog, we are basically a transaction. And from that point, from my perspective, from that, I was like, oh, that's true, and really made me think about really what adoptees are.
Yeah, thank you for that. Dr. Nizar, in terms of how we define disability here in the U.S., is there anything you'd like to add?
Yes, I think that disability, Michelle, really good question. So disability is probably the largest minority group that anyone can fall into at any time. And it's really interesting that my journey focused so much on disability. I was doing disability advocacy and disability rights long before I actually got into the rare disease space, and I find that there's so much intersection between the two worlds. And what I begin to see is that if you have a rare disease, the chances are you also have some form of disability as well. So some of the work that is done in the disability space is really a blueprint for a lot of us within the rare disease space to advocate for in terms of policy changes. If you look towards the ADA and the work they've done in the space to begin to change and make the world more inclusive or accessible to them, it does give us a greater access to, okay, what does need to be done. But often in the rare disease space, when we talk about equity, we often leave out disability, even though it stares us in the face all the time. And when we think about disability, we think about, oh yes, I have a ramp in place, and we check a box. And often we fight to even include disability in the definition of diversity, whereas, as you've mentioned, a large percentage of people who are underrepresented are disabled.
Thank you so much. And then Dr. Hiratsuka, appreciate the land acknowledgement so much. Is there anything else we should acknowledge about our discussion of the Indigenous community?
Sure. A couple different things come to my mind. I'm not going to read a definition, as both of my colleagues here have done, and they've spoken from their lived experience. And although they're both individuals that could also create and have, I'm sure, definitions of that they were both describing that we can all cite in the future. I'll just share, as I speak about Indigenous peoples and Indigenous experiences, I'm speaking of the experiences of those that have walked on these lands and have been of this place for tens of thousands of years. Here in the United States, we often refer to federally recognized tribes, and I myself am an individual from a federally recognized tribe. My enrollment is with the Navajo Nation, but I'm also from a non-federally recognized tribe, a tribe here in California that was disenrolled, that had been removed from tribal recognition. And with that, there are so many other groups that are state recognized or just not recognized here in the United States, in our territories, but worldwide. And the Indigenous peoples of various areas of the globe have different ways that they've been connected to their land, to their flora, to their fauna, to the cosmos. And that's part of what I'm alluding to when I'm speaking of Indigenous peoples.
Thank you so much for that definition. So Daniel, I did want to ask, how have your lived experiences as an adoptee impacted by a rare disease shape your work in this community?
I mean, when I was younger, I got some good support as well when I was a child, but transitioning into adulthood, my parents weren't as supportive, or I should say active within my health condition. And therefore, again, back in 2017, I was really looking for answers to connect with other people with TSC. Not even just TSC, but really find answers. And as a Chinese adoptee, they ask you to know your family history and all this other stuff. And it really made me think about just my own health in general. And I was just going to the TSC Center of Excellency and all these other people who literally knew read your medicals from other doctors and whatnot. Really, really impressed me, but also just finding that support, finding people that really are there for you. I only have like 1 or 2 friends that I really go to, and we talk about things like this, and that are there for you to support you and be there for them as well.
Thank you so much. Dr. Nizar, the FDA has made recent advances surrounding diversity within clinical trials. Can you talk about the impact of clinical trial research in the disability community?
Yes, thanks, Michelle. So we are going to have more of this in tomorrow's session, but I did want to touch upon it, as I mentioned earlier. As we begin to work towards treatments for your own organizations and your rare disease, I think it's really important to keep asking yourselves, are people with disabilities being included in the trial design? Very early on in the discussion. So if you are meeting with your sponsors, you need to start asking these questions early on, because remember, it's really far from their idea of what diversity is defined as. So you have to make the constant reminder. If you look at clinical trials, they've historically left out people with disability. And if you see, even an example is with Alzheimer's research, we know that 60% of people with Down syndrome will get Alzheimer's, and yet they are not included in clinical trial research. So when we think about designing for clinical trials, we must be the ones to constantly ask, is the trial criteria for the protocol inclusive? Do we have vague exclusionary policies in place that are actually eliminating people with disabilities from even participating? So consent forms, are they also inclusive in the way they're put together? Do you have an auditory version of it? Do you have a video version of it that becomes a little bit more inclusive? When we talk to people in the disabled community, many of them want to participate in research, but it is a very inaccessible world. So if you think about how you got your diagnosis, what did you do? I mean, the first thing I did when we started finding that my son had a skeletal disease, and I had a misdiagnosis for 32 years, the first thing we did was go to the internet. Now think about the people who are unable to see or hear or read using the internet. Are they going to get a diagnosis very easily? So I think earlier on when we introduced the room and the sessions, we talked about the added layer of difficulty when you throw in a different minority group into the mix. So when you think about clinical trials, think about how will we ever learn of different trials? Is your website accessible to screen readers? Do you have material that has large print, that has accessibility features? So if you don't have these things, then we are absolutely excluding an entire population who really want to engage and want to be present and want to be included. And remember that when we do have treatments that come out and this whole majority of people are left out, guess what? You're not really showing efficacy down the road in longitudinal studies, because they will at some point impact your trial results. So do the legwork right at the start in terms of engaging before a clinical trial even begins to start up.
Thank you so much. I think we were sharing a conversation earlier today as well, but talking about the nuance when we're communicating about the disability community and the variety of solutions. You brought up a few, but I don't know if there's anything else you want to add in that regard.
I think that, yes, the nuance is so important. Not everybody with a disability wants a cure or wants a treatment, and we really need to be sensitive to that. And the only way you will know that is by engaging with them and by listening to some of the things that they are saying. And listening and learning from communities is important. Sometimes you can have a trial that is for a particular group of people and then turn around and realize, why didn't we enroll, or why aren't there patients? Because guess what? The community never wanted that. right? So we have to remember that there's such a spectrum in the rare disease community, especially when it comes to disability. And the only way we can understand that nuance is by engaging with them. And sometimes it's really difficult. And I've had people tell me that it's kind of scary. Sometimes it seems intimidating. And I've had this even in my personal work where people say, you're pretty intimidating. Why? In what way am I intimidating? So, and that can be a very biased and very, very offensive term, because I'm like, is it the wheelchair that's intimidating? Is it because I'm speaking? Well, I never thought that you would speak in this way. What does that mean? So you have this preconceived notion about how disabled people should be. And that's because of your bias that has been historically in place for years and years. Sometimes, and I'll share this joke. It's not really funny, but anyway, my kids, they both are users of wheelchairs, and all the time they come to me and tell me different ways in which people accosted them on the road, right? So little children will come and say, oh my God, what happened to you? Because, they are so unabashed and not bound by any societal trappings, and so they'll ask, oh my God, what happened to you? And my kids crack me up because they come up with the most amazing replies. I got hit by a bus. Mm-hmm. Or they'll say, I fought the tiger in the wilderness, and they'll be like, really? Yeah, you should have seen the other guy. Mm-hmm. So all of these really begin to change your experience about disability, unless you have people who have disability in your workspaces, in your organization, in your advisory boards. You wouldn't really know how to deal with them, because historically, people with disabilities have been sidelined. I grew up in the Middle East in schools that were segregated, in the sense that if you had a disability, you went to a separate school entirely. So my father insisted that I go to a regular school, and he would carry me up 2 flights of stairs so that I could attend school. Here in America, we have the ability to have people with disabilities in the classroom. But even in our workspaces, we have to fight to get into those positions. Same in the rare disease space. If you don't see them, they don't exist, right? But they're there. And so you're perpetuating a cycle. You don't see them, you don't invite them. You don't invite them, they don't get counted. They don't get counted, and you just continue the vicious cycle.
Thank you so much.
I spoke too much.
Not at all, not at all. Very insightful. Yes, thank you. Dr. Hiratsuka, in academia, universities are often at the forefront of a lot of the research that we see published. How has your work in health equity surrounding Indigenous populations changed over the years?
A couple of different things. One is, I think so many universities and professors think they're at the forefront, and just because their names are published there with their university title at the bottom doesn't mean that they really are. So many of us that do have positions in the academy are not at the forefront. Instead, those with lived experience and their family members are indeed at the forefront. Their stories just are not told and published in the same way. I think there's so much that comes from the lived experience, and partnering as an academic with individuals with lived experience and seeking ways to amplify their voices is one of my ultimate goals in the work that I do. I think there's so much time and energy that those of us that get placement in the academy end up taking up a lot of oxygen in the room, and so I am just excited, lady, to get to hear from you, doctor, and to hear exactly those things that you guys are sharing, that you're sharing here on this panel, and that's what we then get to, those of us that wear the hat of an academic get to learn from and work from. And so I think about my own work history. Like I said, I am a person that is trained in public health and come from an Indigenous background. I work for Indigenous organizations and only recently came to a university. And I thought I was doing pretty good in the way of working in diverse populations, understanding different needs, because I was seeking to bring in inclusion of Indigenous populations to other public health settings. And it wasn't until a few years of practice therein, I started feeling real uncomfortable because I didn't realize how unequipped I was in doing what I thought I was doing well. And I started feeling really uncomfortable. And I could either step forward into that discomfort and figure out what else was there in the way of my ableism or not, and just keep on doing what I was doing, which was fighting every time that an intervention was supposedly, tailored to Indigenous peoples because a feather was put on something or a dream catcher. And I would argue about that, of how that's not a representation nor equitable inclusion because of just a simple icon addition. But I also was realizing, gosh, there's a lot that I don't know and I'm not doing in my practice, and it made me feel ashamed. And so I needed to not just hear, but change my practice, and it's something I'm currently doing as a researcher of longitudinal cohort trials and things like that, of hearing that indeed my informed consent forms do need to have an audio version. And this was one thing that I've just been thinking about, of like, okay, I do need to make that change, and I haven't done that yet, despite working in the field of disabilities for 3 years now exclusively. Okay, so I'm always learning and trying to grow there and do that with the teams that I'm working with, and remind others maybe that are not focused in the same areas of, here's what we also can do, and here's how we can go about that. And then finding friends that I can run it by and go, hey, did I get it? Or am I still off base? And trying to learn how to feel comfortable in that space of when I am still off base, when I didn't get it, and what I can still learn and grow in. And so those are some of the things that come to my mind from my own lived experience, just, learnings within the past couple of minutes, which I really appreciate. And I think I wouldn't get unless I was in relationship with others and willing to try and do better.
Thank you so much. I think that's a good lesson for all of us here today. We're here because it's okay to be uncomfortable, and it's important for us to be uncomfortable because I think you mentioned earlier that's how we grow. So one other follow-up question to that, but what strategies have you, your community partners, and other collaborators done to then address equity?
Yeah, one of the things that I'm one of those weird people that likes to read all the time. Like, I'm a nerd at heart, right? Which is why I went into research. And I read about research, so it's really kind of meta, this thing that I'll share, but it's research on community-based research has shown that in power sharing, we get more of the long-term and intermediate outcomes we want in that type of research. And so with that, it's about sharing of that air, that space, that time, but also about sharing of the money. And so some of the stuff that I've been learning and doing is practicing what I preach then, is to make sure that when we are in coalitions, when we do have grants and other things, that we are indeed hiring from within the community, that we are doing that type of training, that people get that type of authorship that others are getting, but also that the dollars are going out to my community partners in a way that isn't just performative, but is substantial to do the work. And again, it's really uncomfortable practice, but a little bit of that practice is shown to make a lot of that difference that we're hoping to make. So those are some of the things that I've been doing administratively as a researcher, but also just in practice to do a little bit better. And yeah, it's uncomfortable, on the pocketbook, on the staff, on, but it's the way that we make change is through those incremental things. So I just submit those as some of the ideas that others might wish to try, because it's proven to get us closer where we say we want to be.
Thank you. And Daniel, I want to go back to you. You bring up Dr. Hiratsuka, the conversation of power and this power sharing. And Daniel, I think you brought up a really good point when it comes to adoption. There's a big power difference in between, somebody who is adopting someone else and the adoptee. Can you talk about the experience in the community and in ways in which you have found it being more inclusive within the community? So when folks, are are coming together, that community that you found within adoptees and founding that support network, how has that helped other families who maybe have not have the power of the lived experience that adoption has, been beautiful and wonderful? When there's conflict, how has the community been able to support each other?
I think finding your own people, finding the people that, again, you trust, but select the people that you trust as well, but also just checking on each other as well. I'll just say we in the adopted community. I mean, I think we want to be visible. We want to be seen, and I think it's just so many in the adopted community. They think that you have a great life. You went to a Western country or some country that has very good amount of healthcare or whatnot, and yet you should be grateful. But no, there's so much that in the adoption community people don't realize, that once you adopt a child from any country, there's so much trauma, there's so much pain, there's so much suffering that people don't realize. And yeah, I mean, it's for myself, I still struggle with a lot of that pain and that sorrow. Even just for myself, I don't know about my siblings as well. But it's hard, it's challenging, and really, again, we want to be seen, we want to be visible, just be there for each other.
Yeah, thank you so much. So Dr. Hiratsuka, going back to you, what are some cultural considerations for researchers and program designers to be more inclusive of the Indigenous community? You brought up not just putting on, a logo or a feather or a dream catcher. What else can others do?
One thing that I think about with culture, with racial and ethnic backgrounds, is to recognize that some of these labels that we have are definitions that we have, right? American Indian, Alaska Native. Within that grouping, we have over 500 different unique tribes. In the state of Alaska alone, for federally recognized tribes, the number is 229, I think. And each one of those different tribes has its own history and story. And so that's why I get prickly when I see something that is, it's culturally adapted to American Indian, Alaska Native people. If so, which people? And I think that can be said of so many different racial, ethnic backgrounds, genders, on and on and on, as we talk about, or disability, rare, ultra rare. Again, within any of these areas, there is unique shared stories and individual stories. And so, when I say these things, I also put this little caveat there of going, okay, if we are seeking to develop materials, do outreach, remember this or that, we also need to remember that in these histories, what is shared and what is unique. And how do we find that out? Well, you can do your own research, but I always think the best thing is talking to somebody and asking, what is that to you? And so, again, awkward, but being comfortable with that awkwardness and seeking to unpack what that lived experience is, I think, extremely important. And in the meantime, trying to be gentle with yourself and with others, and do the best with what you got right now and try to do better in the future, right? Just that really pragmatic type of way of being. I did want to also just bring up a few things in the way of shared experiences. And as an American Indian person growing up here in California, I mean, there were so many things that I think I found that were shared with, let's say, my husband, who is an Alaska Native man growing up in Alaska in the same time period, right? And we found that we did have similar lack of access to basic things like healthcare. We both were recipients of what was Indian Health Service at the time, now tribally directed healthcare services operated through Indian Health Service. But we still have difficult access to primary care, let alone genetic testing and genetic counselors. There is still a difference in the way that we might, through that healthcare system for Indigenous peoples, access then specialists or not have specialists that we can speak to. There's a difference in the way of diagnosis. There's a difference in the way of medicines that are going to be available through that type of healthcare system. And of course, there's differences in the way that research will be conducted, differences in the way that our tribes would like to have tribal sovereignty over data, differences in ways that even between myself and my husband or within my own two tribal backgrounds, my two different tribal backgrounds might think about biospecimens that I would like to provide for genetic testing. And then also differences then in some of the ways that we might think about the effects or need for different N of 1 studies or small intervention studies. So those types of things can really only be learned in discussing with a person what that might be, and having, working through restorative practices as a clinician, as a researcher, as a family member, et cetera, in the way of asking those open-ended questions and being willing to receive information that may be antithetical to your own understanding.
Yeah, thank you so much. So Daniel, same question for you. What are some considerations for people working in the rare disease community to be more inclusive of the adoptee community?
I think it's mainly about most adoptees want to at least know some sort of history of where they come from, or at least for myself. Really think about, when they think about your family tree as well, not every single person, not even just adoptees, but anyone, just like for myself, I'm LGBTQ as well. And you gotta think about those people that don't have access to their medical records or their family tree or whatnot and so on. Thinking about that, even just thinking about from the last Health Equity Forum back in Atlanta, there was a family that was just thinking about me, and she adopted a child as well. And they're just thinking about all the challenges that, as adoptees, that we face to get health records or whatnot, and so on. And it's the challenges that we face that we don't have. Like for my siblings, they have access to their family, well, at least to their direct family from South Korea. I mean, like from a Chinese adoptee, we don't have those aspects. You have to go searching for those. And it's some of those challenges there that people don't realize. And I think it just giving a seat at the table for in this industry as well. Have a seat for the adoptees, for anyone that's within the adoptee community. Have a seat at the table. And that's really important. At least the last year, from the last Health Equity Forum that I went to here, I think that's really important. Having a seat at the table, regardless, for anyone that wants to adopt.
Yeah, thank you so much. Dr. Nizar, what cultural considerations should companies, organizations, and researchers make to be more inclusive of the disability community?
I think that one thing to keep in mind culturally is how we see disability across the globe. So in many Asian communities, my roots are from South India, and we see disability as a stigma even today. So, many families would be very embarrassed about having a child with a disability. They would, try to hide it away. And so if you have that mindset, then even getting to a diagnosis is really hard because you don't even want to acknowledge the child. In many Middle Eastern countries too, having a disability is frowned upon. And so, it's a stigma to the whole family, to the honor of your family name, your bloodline, and all of that. So even understanding that and trying to engage with communities that don't see disability as something positive to celebrate. Whereas here in the Western, in the Western world, we see it as a social justice, cause. And we see so much influence with, just the social media is rampant with people with disability talking about their rights and demanding their equal rights. Whereas in many parts of the world, disability is shunned, they're hidden. And so to have that broad understanding and sensitivity to the culture is going to be really important to engage these communities. And to be able to, and again, I just want to preface all this by saying, I don't expect all of you to go and hire somebody from India or somebody from the Middle East into your, organization so you can begin to do that work, but to really know that there are organizations already doing the work. There are frameworks in place that allow you to engage with these communities. But I think it's the power of partnerships and the power of relationships that doctor was speaking about that is so important for us as patient organizations to leverage, right? And remember, we are all still a minority in that we are a rare disease, and we, only 5% have approved treatments, so we're all fighting for that same pot of gold and resources. So it doesn't make us in any better position except that we have a leg up in all of these diagnostic tools, access to just that social equity, right? Whereas we're able to gather here today to even discuss this, whereas maybe others who have similar conditions cannot, because they don't even know it exists. They don't even know that, they don't have the social capital to be able to know that there is an injustice happening. So just imagine you're at the starting line, but there are 10 different people way behind you that don't even make the starting line of your race. That's when you think about the disparities and how we can begin to address them.
Thank you so much. Well, I know we're getting close to the end of time, so would love it if everybody here can share, one or two key takeaways for this group, and then we'll open it up to questions. So Daniel, I don't know if you'd like to go first.
So some of my takeaways would be take one day at a time and don't stress away about things that you can't control. And live life to the fullest. I mean, we all are so busy with our daily lives, making money, supporting our family, whatnot. Slow down. Enjoy the moments that really matter to yourself. Sometimes you have to be selfish to put for yourself. I mean, I still myself struggle with that as well as slow down, but really enjoy the moments that really, really matter to yourself, so that you don't look back and regret that.
Thank you. Dr. Hiratsuka?
Thank you, Daniel.
Yes.
I really needed to hear that today, so thank you. And I'm sure others did too.
Yeah.
I would like to share two things. One is that everybody has something to contribute, right? So finding that within one another is so important. And I think we find that through relationships, through letting somebody share, to ask, to be truly inquisitive about others' lived experience. I think that it's through those stories and those heart connections, those spiritual connections, that we really see one another. And so with somebody sharing their lived experience, to honor that, to remember that they're sharing of themselves, and that is huge, that is everything. And it's a wonderful, wonderful gift to receive. So that was one thing. And then the other is that all of you are leaders. If you're like me and you prefer to be the guy behind the guy, that's okay. But also in doing what you are doing and who you are contributing. You are amazing. You are needed. And you are powerful in what you're doing. So please keep on doing that. But also, as Daniel had said, got to remember yourself in that. And so I just really wish to elevate and honor all of the work that you are doing, and thank you for being you.
Thank you. Dr. Nizar?
Yeah, I think that was beautiful.
Yeah.
Okay, but my main takeaway is that, so I'm a patient organization leader as well, right? And none of us as we run our organizations, if there is a patient from, say, Brazil who reaches out and says, I have a son or a daughter and they've just been diagnosed, none of us would say, well, I don't have time for you, right? We are intrinsically motivated to help and reach out. Oh, there's another patient, we're so excited, we embrace them. So by default, we are doing good work in the sense that we are there for our community, no matter where they are in the world. We are always ready to embrace. I think that, sessions like this make us realize that there is something more we can do. However, I don't want anyone to think, especially from this session, yes, I've got to do diversity now, on top of raising this much money to get my treatment to trial, and I need to also have my board meeting, and I need to make sure that I write this grant. It is a long-term kind of commitment. It's not something that you're going to reap benefits tomorrow or today. It's just a commitment mentally to know that I'm not going to have any barriers in place for any kind of patient that comes to my door, right? And that's an internal commitment that we welcome all and we're inclusive of all, right? I think in Africa they say, I see you, right? In their greeting, instead of saying hello, they say, I see you. Because I see you, I accept you as an individual with everything that you bring to the table. And it really echoes, the words that we're saying, I want to be not just seen, but visible, which I thought was just beautiful. Mm-hmm. And so I think that's important. And if you can go away from this summit, at least having everyone in the room and you get a contact, you've done really good work for today, because everyone in this room is doing equity work. That's why you're here, because you want to know how to do better. And so if you can take everyone's LinkedIn address and write to connect, because there's already so many frameworks in place, and it doesn't have to be all on the patient advocacy organization to do. Please remember that this work is being done by lots of people, and you don't have to add that also to your repertoire.
Thank you so much. So I'll open it up for anybody who would like to ask a question. There's 2 microphones up here. We've got about 10 minutes left.
This is an absolutely phenomenal panel. My name is Beatriz My name is Beatriz Mallory, and I have an organization called Herd Kids. Our work is supporting low-income kids with rare diseases by connecting their families with organizations such as those in the room that they don't know exist or can't help them. But I'm here representing the disability community as someone with thyroid eye disease, and also being on the board of Easter Seals of Southern California.
I love Easter Seal.
Mm-hmm. Well, we love y'all. Well, we just had a board meeting, and literally I told them I was coming to this event, and I asked about, would you, any of you, be interested in being involved in this community? And right off the bat, people said, nope, because we are viewed as a burden. Someone with hearing impairment, I mean, there's not an interpreter here, right? So they right away are saying, well, I'd have to be the one to make the accommodation. And then someone says, an informed consent form that isn't in Braille.
Correct.
I mean, these researchers just don't have any clue. And frankly, I can have diabetes 1, and I was just hit by a car. So there's no genetic reasons why I can't be in a study. But they see me in a chair, and they assume there's something that's going to make me a disconnect.
Right.
So I don't mean to really talk to you about this specifically, but it's a basic things that are also affecting intersectional work in clinical research.
Mm-hmm. Yes, absolutely.
Yeah.
Absolutely. I mean, you bring up a really good point. It's, again, it's our biases, right? You already, off the bat, you've excluded people who could otherwise be included if you had just taken the time to listen a little bit. I think that, sometimes we need others to go to bat for us, right? We do need people to say, hey, what about this, right? So bring those uncomfortable conversations to the table. It only really takes one person to be in the room to say, hold up, what about this? And I think we were talking about that, to have different voices at the table to challenge the conversation, right? If you have 4 people from a similar background, they're all going to say the same thing. You bring somebody else into the mix, and you're going to have a different perspective entirely. And be ready to embrace that discomfort, I would say.
Thank you. Next question.
Good afternoon. My name is Andre Harris, and I represent the Sickle Cell Association of Houston. I also live with sickle cell disease. My question and comment is, I appreciated, Daniel, I believe is your name. Okay, I'm glad I remember that. You mentioned being LGBTQ plus and also part of the rare disease space. Can you and/or the rest of the panel talk about what your recommendations are, or what do you think would be the best next thing to do in regards in including LGBTQ voices and identities in the rare disease space? Because that's something I'm interested about, like what's on the horizon, what are we doing? Because I think that's important not only are there just overall health disparities, as we all know, for that population, our population, but it's also more poignant in the rare disease space. So I'm very interested in how to move forward in making sure that this population is represented properly.
I think really about is connecting with so many people just in the rare disease and in the LGBTQ community, finding those people and those voices, empowering them, and again being seen, be heard, and allowing them to sit at the table, really, because it's the next generation. The way we are progressing in some parts of this country, I don't know, but other parts of the world. I mean, not every part of the world has LGBTQ-friendly parts. I mean, just from my aspect of where I'm from China, they don't. It's considered like a taboo, or it's against a belief, and therefore it's you just have to empower yourself to find those people. I don't know if you have.
I think that is Tina Orva in the room from the NCATs? You should connect with the NCATs, and I will connect you for sure. They are beginning to do some work around this area in terms of policy as well. So that would be a really good place for you to start to begin to bring that to the table and say what, sometimes it's around the policy, like how do they define certain terms in research? And that's where everything stems from. So if you can attack it at the roots and say, hey, we want to be included, and so have conversations with the people that are important to make those decisions happen, I think that's your best chance. But thank you for coming. I think that's wonderful you're here.
Thank you for that question as well.
I think we'll go here for the next one.
Hi, everyone. I'm actually Tanisha. I actually don't have a question. I think you did fabulous. But in the spirit of disability, if you have a question and you cannot walk up or make a way to the mic, I'm happy to walk around and pass out the mic as well. So I'll be here for this session and an additional session and some sessions tomorrow. So I just wanted to make that announcement that we do have that. So if you need that, just raise your hand a little bit and I'll come your way.
Tanisha, you're amazing. Thank you.
Thank you.
Just a super quick comment with regards to LGBTQ. There's actually now an organization in the biotech industry called outbio.org that has gathered together the various individuals within the biotech industry who represent that community. So I would suggest anybody who's working in that area look online, outbio.org, and see what information might be available in terms of some of the biotechnology companies that are working in rare disease, since there's so many, a growing number of people from that community within biotech. Thanks.
Thank you
Thanks
for
so
that comment.
much, Eve.
Hi, Kevin Fryer from Salem Oaks and from Rare New England. I was struck by what Mario said, that there's 50% of the people in the country who don't recognize that there's these disparities. And then I see you guys up there. I mean, Daniel, you were nervous to be in freshman orientation, what, 2 years ago? And there you are on stage. Love it. But how do we get those people in the room to have the opportunity to see this in reality?
I didn't understand the question.
Anyone can answer it.
Yeah, I think if I can reword your question, maybe it's about bringing folks to the forefront to have this conversation and opening the door so that this conversation can happen in multiple communities. Is there anything you'd like to add based on that?
Yeah, I think this is exactly what each one of us gets to do all the time. And I encourage each one of us to not just open the door, but find every window and get a sledgehammer to the walls. Honestly, yeah, because every time I get invited to a meeting, I like to do that. I like to invite others to the meeting. And I've been learning how to do that through one of my sister-in-laws, who she shows me through her boldness and her courage of how to maybe break some of those social norms, so that way others that ought to be in the room are there. And so just, again, an homage to her. because that's something that I struggle with. I struggle with things like protocol of what is normal, and then feeling like I'm kind of there by invite and shouldn't be doing additional things, like you don't get a +1. Well, and then I come and roll up with a +3, and and then that's just, I think, something that I'm trying to get better at, and encourage all of you to, again, try to live in some of that discomfort and ask those questions, or don't even ask, just do, and see what happens. And again, these are things that I've been learning from some of the younger people in my life, of trying to get comfortable with that discomfort. So that's one of the things that I'm trying to do better on, and that's how I think we make those changes, is by making the change instead of expecting it to happen, because it hasn't happened just yet. So we can make it.
I think from the disabled perspective, it's a really good question. How do we get more people to come to the forefront? Make more accessible events. Make it so that your events are easy for us to get to. This was wonderful that the location was right next to the airport and they had an accessible shuttle, so we could get here. I've been to events where you couldn't even reach the venue, and once you did reach the venue, it was not at all accessible. I've been at events where they've had a chair on the stage and have asked people with dwarfism to climb the chair to reach the podium. Kid you not, this has happened. And so if you have such events, they're not going to come. Like you mentioned, there's no audio that you would like to have in place for you. Have a list of accessibility requirements at all your events. Make sure that you're giving people the opportunity to say what accommodations they would require. I definitely would not go to an event that was not welcoming in those aspects, because it's just not practical. It's stressful. My wheelchair breaks. Everything is a disaster, and I'm probably going to be out for the next week after that. So, yes, make your events accessible, and we'll come.
And I'll just say one thing. I think it goes back down to accessibility. I think it's really important as we progress, moving forward, to have those accessibility options for those that can't even make it to this event or other events in the future. Have it virtually online, because some people in this community, they can't make it due to maybe financial reasons, stress. It takes so much energy out of them. They can't have someone who needs to take care of their child or whatnot, and so on. And we need to have accessibility for everyone, regardless of their situation in life.
Thank you so much. And I know we're all out of time, so I just want to give a huge round of applause to everybody up here.